the little pill you've swallowed every single morning for the past 12 months. Amlodipine, Losartan, or Lisinopril, sitting quietly on your kitchen counter next to your coffee cup. Now ask yourself honestly, if I stopped you right now and asked what that tablet is actually doing inside your arteries at this exact moment, could you answer? Not the folded paper insert nobody reads, not the one line your pharmacy tech mumbled at pickup. I mean, really understand it. How it operates in your body, how it can shift from helpful to harmful under the wrong circumstances, and which warning signs mark the difference between something trivial and something that lands you in an emergency room. I ask this question constantly to smart, capable people. People who balance their own checkbooks and follow current events closely, and 9 times out of 10, they freeze. That silence tells me something important. Because let's be clear, these are not gentle supplements you can shrug off. Amlodipine, Losartan, and Lisinopril are serious pharmaceutical tools that reshape how your heart, your blood vessels, and your kidneys behave every hour of every day. Yet countless seniors swallow them on pure habit, with almost no real sense of what to look out for, what to steer clear of, or when an ordinary symptom is actually their body waving a red flag. That ends today. I'm Dr. James Myers, and this channel has one mission: handing you the straightforward, no-nonsense health knowledge that gets skipped over in a rushed 10-minute appointment. By the end of this video, you'll know these 3 medications well enough to feel steadier, sharper, and far harder to blindside. Let's start with a story about a man named Gerald, because what happened to him lays the groundwork for everything ahead. Before we dive in, drop your name and the town or state you're watching from in the comments below. I read through every single one, and I genuinely want to know who's sitting on the other side of this screen. Gerald was 74, a retired engineer with a mind built for precision. He never missed a dose. His daughter had arranged a weekly pill organizer, and Gerald ran it like a project timeline. When his physician layered amlodipine on top of his existing prescriptions, Gerald shrugged it off as simply another blood pressure tablet, same family, different name, nothing to think twice about. That single assumption nearly stole a good year from his life. Within 3 months, Gerald's feet had swollen so severely that none of his usual shoes would close. By late afternoon, his legs felt like sandbags. He started cutting his walk short because moving made everything worse. He confided in his son that he suspected his circulation was collapsing. Fear set in, and he began searching online for heart failure symptoms. The true explanation turned out to be far simpler and far more fixable, but Gerald had no way of knowing that because nobody had ever sat him down and explained that amlodipine, Losartan, and Lisinopril, despite all lowering blood pressure, are 3 completely different tools built on 3 completely different mechanisms. That's where the resemblance ends. Amlodipine belongs to the calcium channel blocker family. It loosens the muscular walls lining your arteries, allowing blood to travel with less friction. Lisinopril is an ACE inhibitor, meaning it shuts down a particular enzyme responsible for constricting your vessels, and once that enzyme is blocked, pressure eases. Losartan is an ARB, an angiotensin receptor blocker, acting on nearly the same hormonal pathway, but through a different entry point entirely, a distinction that carries more weight than most people assume. 3 separate mechanisms, 3 separate risk profiles, 3 separate things your body might tell you. Once you grasp that, you stop reading every symptom through the same generic lens. Gerald's swollen legs were never heart failure. They were amlodipine behaving exactly as amlodipine behaves in a meaningful share of the people who take it, loosening arteries far more than veins, and letting fluids settle low in the legs. Once that pattern was recognized and managed, Gerald was back in his walking shoes within a matter of weeks. The name printed on your prescription bottle isn't just a label, it's a category, and that category is the key to reading your body correctly. Let's slow down and unpack that swelling, because it might be the single most misread side effect in the entire world of blood pressure treatment, and it touches a surprisingly large number of people on amlodipine. Here's the plain mechanics of it. As amlodipine relaxes the narrow arteries feeding your lower legs, blood arrives more freely, but the veins tasked with returning that blood upward toward your heart don't loosen in the same way. That mismatch creates a bottleneck, more fluid flowing in than flowing back out. Pressure quietly accumulates in the tiny vessels around your ankles and feet, and eventually that built-up pressure forces fluid straight out of the vessel walls and into the surrounding tissue. What shows up on the outside? Puffy ankles, sock lines pressed deep into the skin, shoes that suddenly refuse to fit, and legs that feel waterlogged by evening. This has nothing to do with eating too much salt. It isn't your kidneys shutting down. It isn't the beginning of heart failure. In the overwhelming majority of cases, it's simply a predictable, mechanical consequence of how amlodipine functions. Now here's where real danger creeps in, not from the swelling itself, but from how people react to it. Some quietly stop taking their pills without telling a soul, and their blood pressure silently creeps back upward while they congratulate themselves on a smart decision. Others keep taking the drug but start cutting back on water, convinced they're retaining fluid, which is exactly the wrong instinct, since dehydration on a calcium channel blocker brings its own set of hazards. Others, like Gerald, simply grit their teeth for months, walking less, fearing the worst, and losing quality of life for no reason at all. Here's the move I want stamped into your memory. Swollen legs on amlodipine belong in a conversation with your doctor, not necessarily because the medication is wrong for you, but because there's often room to adjust, alternate, or manage it far more comfortably, elevating your legs, changing when you take your dose, or in some situations, exploring a different medication that suits your particular body. None of those solutions arrive, though, if you stay quiet and just endure it. If this sounds familiar, drop a comment below. Have you noticed your legs feeling heavy and swollen by the end of the day? You might be shocked how many people are quietly dealing with the exact same thing. Now let's turn to Lisinopril and the side effect this drug class is most infamous for, the cough. Not the wet, productive kind, but a dry, scratchy, relentless irritation at the back of your throat that tends to worsen once you lie down at night and refuses to respond to lozenges, syrups, allergy pills, or anything else in your medicine cabinet. Here's what makes it so easy to miss. It rarely shows up right away. A handful of people notice it within the first week, but many don't develop it for 3 or 4 months. And by then, the idea of connecting it back to lisinopril never even crosses their mind. They've already been taking the pill for a while with 0 issues, so they blame dust, seasonal allergies, a cold that won't fully clear, or acid reflux. Let me introduce you to Margaret. Margaret was 71, a devoted gardener, and she was convinced her cough was simply pollen catching up with her outdoor hobby. It began in late spring, which made her explanation feel completely reasonable. She reached for antihistamines. She bought an air purifier. She mentioned it to her family doctor, who ordered a chest x-ray that came back perfectly clear. 6 months later, the cough hadn't budged. Her sleep was fractured nearly every single night. Exhausted and on edge, she started fearing that something more serious was being overlooked. When she finally came to see me, one of my first questions was simple. When exactly did you start lisinopril compared to when the cough began? She paused, pulled out her phone, and started counting backward. She'd started lisinopril 11 months before that appointment. The cough had crept in around the 4-month mark. She had never once connected the two. Once we identified the likely trigger and coordinated with her primary doctor to transition her to Losartan, which works through a related pathway but doesn't carry this particular cough risk. That throat tickle disappeared within 2 weeks. 11 months of broken sleep, resolved in 2 weeks, the moment somebody linked the dots. Now here's something absolutely critical, and I need to draw a sharp, unmistakable line. There is one symptom within the ACE inhibitor family that is not a mere annoyance, it's a medical emergency. If you're taking Lisinopril and you notice swelling in your lips, tongue, face, or throat, especially if breathing or swallowing starts to feel difficult, you do not sit and wait. You do not plan to call the clinic in the morning. You do not pop a Benadryl and hope for the best. You call emergency services immediately. This condition is known as angioedema. It's uncommon, but it's absolutely real, and it can close off your airway faster than most people realize. A dry cough is simply a nuisance. Throat swelling is a genuine emergency. That distinction matters enormously, so please lock it into memory. And if nobody has ever broken your blood pressure medications down this clearly before, tap that subscribe button now, because what comes next in this video could matter just as much for your safety or for someone you love. Let's shift to Losartan, and a risk I find genuinely fascinating because it doesn't stem from doing something careless. It stems from people trying to do exactly what they believe is right. Losartan, much like Lisinopril, works within the renin-angiotensin system, your body's built-in blood pressure control network. One consequence of this entire drug class is a tendency to raise potassium levels in the bloodstream. For most patients, that stays perfectly safe when properly tracked. But layer certain everyday habits on top, and the whole picture shifts. Here's the twist most people never see coming. Potassium isn't hiding only in bananas or supplement bottles. It's tucked inside products marketed as the supposedly healthier option, salt substitutes. Many of the popular low-sodium alternatives sitting right beside regular table salt, often branded as heart-friendly, swap out sodium for potassium chloride instead. So a senior who's been told to cut back on salt reaches for one of these substitutes, sprinkles it generously on every meal, and unknowingly starts stacking potassium on top of a medication that's already nudging potassium levels upward. That combination can push potassium high enough to interfere with your heart's electrical rhythm. And here's what makes this so treacherous. Elevated potassium doesn't always announce itself loudly. Sometimes it whispers through unexplained muscle weakness, ongoing fatigue, cramping in the legs, tingling fingers, or a fluttery, irregular heartbeat. In some cases, there are barely any symptoms at all, right up until there suddenly are serious ones. Think for a moment about someone close to you, maybe even yourself, who switched to a salt substitute sometime in the last couple of years. If that person also takes Losartan or Lisinopril, that's a conversation worth having with a doctor. Not because the drug itself is dangerous, and not because potassium-rich food is the enemy, but because the mix, left unmonitored, can quietly snowball into a problem that never had to happen. Electrolyte powders, certain meal replacement shakes, and some sports recovery drinks also carry a meaningful potassium punch. They're not prescriptions, so nobody thinks to bring them up, and that's precisely why they slip through the cracks. There's one scenario I don't think gets nearly enough attention in discussions about blood pressure medication, and it hits seniors harder than any other group. What happens to these drugs when illness strikes? Not a hospital-level emergency, just an ordinary stomach bug, a few days of vomiting, diarrhea that won't quit, no appetite for a couple of days, or even a scorching summer week with heavy sweating and not enough fluids. Once you're dehydrated for any reason, the very same dose of Losartan or Lisinopril that was perfectly tuned for a well-hydrated body can behave in a totally different way. Your blood pressure can drop lower than it should. Your kidneys, already under extra strain from fluid loss, become far more exposed. Dizziness, weakness, fainting spells, or sudden kidney strain can all develop faster than most people expect. The medication hasn't changed at all, your internal environment has, and the drug is now operating under conditions it was never calibrated for. This is one of the most practical pieces of advice I can offer today. Illness rewrites the rule book, and if you don't have a plan for what to do the moment it hits, whether to pause a dose, when to call your doctor, which symptoms warrant a visit, you're leaving a serious gap in your own safety net. That plan should come from your prescribing physician long before you ever need it. If you don't already have one, ask at your next visit. What should I do with my blood pressure medication if I catch a stomach virus or can't keep food and liquids down? It's one of the most valuable questions you could ask and one of the least frequently asked. Quick question for you. Has your doctor ever handed you a sick day plan for your blood pressure medication? Type yes or no in the comments because I suspect most of you are about to answer the exact same way. Now picture this scenario for a moment. You're having a rough week. Your arthritis is acting up. Your knees ache. Your back feels locked. You swing by the pharmacy and grab ibuprofen, something you've reached for 100 times before, completely unremarkable, sitting right there on the shelf for anyone to buy. Except you're also taking Lisinopril or Losartan. Maybe you're on a diuretic too, a water pill for additional fluid control. Combine these regularly and blood flow to your kidneys can drop meaningfully. Add even mild dehydration into that mix, and your risk of kidney injury climbs substantially. This isn't some rare hypothetical. It's one of the most common, most preventable situations I encounter. And the reason it keeps slipping through is simple. Patients rarely think of ibuprofen, naproxen, or similar over-the-counter anti-inflammatories as real medications in the same league as their prescriptions. To them, it's just a drugstore item for pain. But your kidneys don't distinguish between what needs a prescription and what doesn't. They respond purely to chemistry. If you regularly reach for anti-inflammatory pain relievers for arthritis, joint pain, or back trouble, and you're on any of these 3 blood pressure drugs, please raise it with your doctor. There are frequently safer paths: acetaminophen, topical treatments, physical therapy approaches, or other alternatives that don't carry the same kidney risk. You don't have to just tolerate the pain, and you don't have to quietly accept the danger either. There's almost always a better route, you just need help finding it. Let's spend a moment on something that seems minor and absolutely isn't: dizziness. That brief spinning sensation when you push up off the couch or climb out of bed in the morning. The room tilts for an instant, you grab the door frame, it passes, and you brush it off as simply standing up too fast. For a huge number of seniors on blood pressure medication, this happens regularly, and it's almost always underreported because it feels too small to mention. Here's what I need you to really absorb. In older adults, a few seconds of dizziness is all it takes to trigger a fall. And a fall is all it takes to cause a fracture. And a fracture, particularly one involving the hip, can knock an older adult's entire health trajectory off course for years, sometimes permanently. This isn't fear-mongering, it's basic physics and biology working hand in hand in a way that deserves genuine respect. The dizziness happens precisely because your medication is doing its job, lowering blood pressure. When you stand up abruptly, your cardiovascular system hasn't had a moment to catch up. Blood pressure dips briefly, blood flow to the brain momentarily thins out, and you feel it as that light tilting sensation. The fix is usually simple. Rise slowly, sit at the edge of the bed for a moment before standing. Hold on to something sturdy as you get up. Give your body a few extra seconds to adjust to the change in position. But beyond that practical habit, dizziness that keeps recurring, dizziness that doesn't fade after the first few weeks on a medication or a near fainting episode, those deserve a real conversation with your doctor. The dose might need adjusting. The combination of medications might need reviewing. Something about your hydration habits might need changing. Staying silent on this is never a small risk. Now let's talk about something that fuels enormous, unnecessary anxiety and occasionally leads to dangerous, impulsive choices for people managing blood pressure at home. Blood pressure isn't a fixed number. It shifts constantly, hour by hour, in response to dozens of factors. How well you slept, whether you had caffeine, whether you're in pain, whether the reading itself makes you nervous, whether you just walked in from outside, whether you were talking loudly right before sitting down. One high reading on a random Tuesday morning after a rough night's sleep doesn't mean your medication has stopped working. One low reading after a dehydrated afternoon in the heat doesn't mean your dose is too strong. What actually matters is the pattern over time, measured consistently, same arm, same time of day, after 5 quiet minutes of rest with no rushing and no talking. When people check inconsistently and react emotionally to single readings, the decisions that follow are almost never good ones. Extra doses taken out of panic, skipped doses because one number looked fine, frantic calls to the doctor over a reading that, in context, was completely unremarkable. Track it with a method, follow the pattern over time, bring that log to your appointment, and let patterns guide the conversation instead of panic. That one shift in approach lowers anxiety, sharpens decision-making, and gives your doctor far more useful information than a single alarming screenshot from your home monitor. If you've made it this far and you're finding real value in this, type the number 9 in the comments. It's a simple way to let me know you're here and following along. These medications work through steady, consistent presence in your system, not sudden spikes and gaps, not extra doses out of worry, and not skipped doses just because you're feeling fine. Amlodipine, Losartan, and Lisinopril were never designed as rescue medications. They aren't meant to be taken reactively the way you'd reach for a pain reliever the moment a headache strikes.